managers, chaplains, all kinds of folks are involved here in trying to understand the phenomena of burnout. And I think it's something that while we won't solve tonight, I hope we come away with an understanding of what it is, what are some of the ways to cope with burnout, what are some of the causes of burnout, and what are some of the systematic organizational problems that create burnout. If you are feeling, whether I didn't go into medicine for this to be managed or told, I have to see X number of patients in Y amount of time, I don't have the kind of interaction that I wanted as a complaint, what can you do to start to personally cope with these feelings or the reality of burnout? And I'll go to Carol first here. Is there, should we all do yoga?
Not for me, maybe for some of you it's really helpful. I think one of the challenges here about burnout, as I was saying earlier, is that how to deal with it, how to build resilience in ourselves is really a very individual thing. And I think what is important is for people to sit and think about the kinds of things that they can do that do make them feel better, whether it's going out for a nice meal, whether it's doing yoga, it may be for some people, or even just having an opportunity to have time off. I think one of the biggest problems, though, is that we face time compression. Everything has to be, there's more and more that has to be done in less and less time, even yoga. So we can't think about that unless we can think of some way to decompress what we do. It may be related to the systems issues you raised, Rob, but we have to figure out within the systems that we work, how can we provide opportunities for us to have both meaningful interactions with patients and to feel better about ourselves without adding another layer on, another regulation, another thing to do?
So I would actually suggest that about 80% of burnout is driven by organizational and systems factors, and a smaller minority, on the order of 20%, is driven by individual factors. So I do think it's good for all of us to be mindful, to do appreciative inquiry, to take care of ourselves with exercise, to get some distance from our work. But I think the most effective things we can do to reduce burnout are to improve workflow. And Mark Linzer's work at Hennepin demonstrates that.
Hennepin County?
At Hennepin County in Minneapolis, they have his research has found that by improving workflow, you can have an odds ratio of 6 of reducing burnout. It's the most potent intervention to reduce burnout. And I think for most primary care physicians, we can save 3 to 5 hours a day by re-engineering how the work is done and by building stronger teams around the physician. And that goes a long way toward reducing burnout.
I just want to note, by the way, before I let Rob jump in, very few people want to take the option of leaving. So what they're trying to do is find ways to either personally cope or do some of these workflow shifts and so on.
Yeah, I think there's some elements that we may miss, that I don't want to exclude in terms of workflow is key. And I would say it's one of the most important things to deal with. But there's something else that I think is really, really important. And that is a lot of physicians feel that they are unheard. They've lost control in their organizations. Let's face it, a lot of physicians in this country are now in employment models or working for healthcare systems, and they feel a lack of control and not being heard. I think that's a critical element. So the way to tackle that, and it's not an easy way, and I think we're all agreeing that it's complex, is to look at the culture, to look at how invested is the organization in tackling this problem, in dealing with it, in not just setting up a yoga or a committee, which is all very good, a wellness committee and things that will start to address the problem and make more awareness. But having a culture where a physician who is experiencing burnout will either feel very comfortable about coming forward and saying, I think I'm burnt out, or will be more comfortable with a colleague coming up and saying, I think you're burnt out. Let's talk about that, and having means of addressing that.
So I heard two things there. One is, it's not necessarily a matter of shame if one responds to tough working conditions with burned out behavior, so to speak. And then I also hear you saying, if you can incentivize the opportunity to make your feelings known, and Rob said this too, if the organization will do that, that gives pathways to at least start to drill into the problem.
I do think change can happen. I think it's critically important to come from the, I hate to say this, but the top down. Leadership has to be genuine and authentic if they're going to say, we really care about how you feel, we care about the system, we want to try and figure.
So should boards and trustees be expecting that from leaders?
Well, I certainly hope so. Again, I don't want it to be just another cog in the machine, but I think authenticity and proof of concept in leadership is critical if this is going to succeed. Because if it's not, if the people at the top don't believe in this and they don't care about it, I don't care what institution you're in, it's not going to happen. Yeah, so, that's.
In coping with organizational change, are there natural allies? Are there people to go to? I mentioned the trustees as one example for the leaders, but should we be thinking about involving patients in helping us struggle with burnout? What do we do to find allies beyond self-management types of solutions, which I'm not against, and clearly streamlining that workflow is drawing attention off of this question.
Well, I'm always a believer that if people come together and can voice the concern collectively, that we'll have much more impact. I mean, I think that's kind of the best way that I can think about it. And the other thing that I've noticed is that as we've started to have this conversation about both burnout and depression, everybody wants to talk about it. So if everybody wants to talk about it, it's clearly an issue that's of concern. And we do better in groups, I think, trying to bring it up the chain in the whatever institution or organization that we're in. I mean, that would be something I would think about off the top.
So one takeaway is that care of the patient requires care of the provider, and that we really do need to focus on health professional well-being, on reducing burnout, improving the opportunities for joy in practice if we want to reach all the other goals. And the other, I think, is that clinical excellence depends on operational efficiency. And if we focus on operational efficiency, we will get clinical excellence, which is what also drives professional satisfaction.
I think many of the solutions that have been described and the observations made have to do with the fact that as physicians, we need to organize in novel ways nationally and speak up in a way that we haven't done since Medicare was passed in 1965. And the purpose of that is to reestablish the relational aspect of medicine, which simply requires time, which is why the entire audience responded to the notion of streamlining workflow.
That are we putting doctors in the position where their training doesn't match the kinds of tasks that they're getting asked to do?
I mean, with the burgeoning tasks that we have now to accomplish, and yeah, Christine and I were having this good conversation about how that has to change. There's no question that, you've heard top of the license. Well, why are, physicians putting in data that can be put in by an MA, or a nurse putting in data that an MA could be putting in, and a front desk staff that should be part of the team? So Christine had emphasized, and I'm going to let her talk to it, but the team-based care model and how effective that is. And you have it in your office personally, so.
So I think, Helen, you're absolutely right that the solution has to involve relief from doing work that doesn't require 11 years of education. And right now, particularly in some fields, physicians are spending the majority of their day doing work that does not require their education and training. And so we have to change that. So one of the things we're doing at the AMA is we're creating a series of practice transformation toolkits. They're free and online. You can go to them now. And one is on shared documentation. We call it team documentation. It's a portion of advanced team-based care where a clinically trained person stays with the patient from the beginning to the end of the appointment and does a lot of work around care coordination, patient engagement, and also helps with data entry. And that has been one of the more powerful ways of letting physicians do physician-level work. So I think you're absolutely right. We have to act like CEOs. We can no longer feel that we can take every single click and task on our own shoulders.
Well, let me thank all of you for coming out tonight. Let me thank all the people who are with us electronically, not in the electronic medical record, but in Facebook and Twitter worlds. I'm sure that Medscape will continue to try and grapple with this issue. I can't promise you I know exactly what direction that will take, but it's obviously a major issue for the audience that works to appreciate Medscape's products and activities.